Anatomy of the breast. An adult female breast lies between the second to sixth intercostal ribs and between the sternal edge and the mid-axillary line. The breast is composed of skin, subcutaneous tissue, breast tissue that includes both epithelial and stromal elements. And epithelial elements make up 10 to 15% of the breast mass, with the remaining being stroma. And each of the breast consists of 15 to 20 lobes of glandular tissue supported by the fibrous connective tissue. Space between the lobes is filled with adipose tissue, and differences in the amount of adipose tissue are responsible for variations in breast size. Blood supply of the breast is derived from the internal mammary and lateral thoracic arteries. The breast lymphatic drainage occurs through a superficial and deep lymphatic plexus, and more than 95% of the lymphatic drainage of the breast is through the axillary lymph node, with remainder via internal mammary nodes. The axillary nodes are variable in number and are traditionally divided into 3 levels based on the relationship with the pectoralis minor muscles. And the sentinel lymph nodes are almost always found in the level 1 of the axillary node. And the internal mammary nodes, they are located in the first 6 intercostal space within 3 cm of the sternal edge, with the highest concentration in the first 3 intercostal space. Lobular carcinoma in situ. In 1941, Foote and Stewart published their landmark study of LCIS, describing a relatively uncommon entity characterized by alteration in the lobular cytology, and they hypothesized that this LCIS was a precursor lesion for invasive cancer. Based on the treatment with mastectomy was recommended. More recently, the atypical lobular hyperplasia has been introduced, described morphologically similar but less well developed lesions, and some centers use the term lobular neoplasia to cover both this atypical lobular hyperplasia and LCIS. Morphologically, this lobular neoplasm defined as proliferation of generally small and often loosely cohesive cells originating in the terminal duct lobular unit, with or without pagetoid involvement of the terminal ducts. In the past, LCIS was most frequently diagnosed in women aged 40 years to 50 years, a decade earlier than the ductal carcinoma in situ. However, recent literature indicates that the incidence in postmenopausal women is increasing. Although determining the true incidence of LCIs is difficult because the diagnosis of LCI is usually made as an incidental microscopic finding in a breast biopsy performed for other indications, and the prevalence of lymph node in otherwise benign breast biopsy has been reported to range from 0.5 to 4.3. LCIs is both multifocal and bilateral in large percentage of cases. In an analysis of 9 studies including 172 patients with LCIs treated by biopsy alone, 15% developed invasive carcinoma in the ipsilateral breast and 9.3% developed carcinoma in the contralateral breast after 10 years of follow-up. Risk of development of invasive carcinoma of approximately 1 to 2% per year, with a lifetime risk of 30 to 40%. In this study conducted before effective breast imaging, 5.7% of the patients developed metastatic breast cancer, and in a more recent study of 776 women with LCIs followed in a high-risk screening program, 13% had developed cancer at a median follow-up of 58 months. A national cancer database analysis of 19,000 patients with LCIs, 10 to 20 year cumulative incidence of subsequent breast cancer was 11.3% and 19.8 and 18.8 to 20% respectively. Subsequent cancers are more often invasive ductal carcinoma than invasive lobular carcinoma, but the incidence of subsequent invasive lobular carcinoma is substantially increased compared to women without LCIs. Although the risk of development of breast cancer is bilateral, subsequent ipsilateral carcinoma is more likely than the contralateral breast cancer, supporting the view that atypical lobular hyperplasia and LCIs function both as a precursor lesion and risk indicator. As LCIS is typically express ER and PR but does not contain HER2, lack of expression of E-cadherin, an epithelial cell membrane molecule encoded by CDH1 gene and involved in cell-to-cell adhesions, account for characteristics histological appearance of lobular neoplasm or LCIS, and invasive lobular carcinoma and distinguishes ductal from lobular disease, both in situ and invasive. Pleomorphic LCIS is a relatively uncommon variant of LCIS characterized by medium to large pleomorphic cells containing eccentric nuclei, predominant nuclei, eosinophilic cytoplasm. As with classical LCIs, it is usually ER positive, negative for E cadherin, also have tested positive for IHC for gross cystic disease fluid protein 15. Pleomorphic LCIs may be associated with the central necrosis or mammographic microcalcification and difficult to distinguish from DCIS. Although pleomorphic LCIs has more aggressive histological appearance than classical LCIs, its relative rarity and the lack of uniform diagnosis criteria make it difficult to know whether pleomorphic LCIs has a different natural history than the classic LCI. Genetic changes in lymph node has been evaluated in a number of studies using comparative genomic hybridization and more recently DNA sequencing. Lymph node lobular neoplasm is characterized by recurrent loss of 16q and gain of 1q, and chromosomal alteration that also been seen with low-grade invasive cancers of both the ductal and lobular phenotype. Targeted sequencing and whole exome studies have also identified shared somatic mutation between LCIS and synchronous invasive lobular carcinoma, and most commonly CDH1, PIK3CA, and CBFB. Further clonality analysis suggests that a significant number of these paired lesions, LCIS and invasive lobular carcinoma, are clonally related and supporting the concept LCIS is both risk indicator and non-obligate precursor of invasive lobular carcinoma. So lobular neoplasia is a marker for breast cancer proliferation, and management must address bilateral breast risk, and thus options include surveillance, chemoprevention, and prophylactic bilateral mastectomy. Mammographic surveillance is strategy selected for most patients. Prophylactic mastectomy reduces the cancer risk of high-risk women by approximately 90%. Chemoprevention such as with tamoxifen, raloxifene, exemestane in LCIs has similar benefit in general study population. The use of chemoprevention was associated with a significantly reduced risk of subsequent breast cancer by 75%. In a large studies, LCIs participate in the high-risk surveillance. And in the last, the finding of this lobular neoplasia on core biopsy prompted recommendation for surgical biopsy to rule out coexisting DCIS or invasive cancer. And recent studies have demonstrated that women with the diagnosis of lobular neoplasm is concordant with the imaging finding. Upgrade rates with excision are very low, less than 3%. This routine surgical biopsy is not indicated. Discordance between the pathology and the imaging and the presence of pleomorphic LCIs in a core biopsy remains indication of surgical excision because invasive cancer is found in 25 to 60% of the cases, and classical LCIs does not require excision to negative margin, nor does it require radiation therapy. However, in pleomorphic LCIs, surgical excision to negative margin is standard, whereas RT remains controversial. Now DCIS is defined as proliferation of malignant appearing primary ductal epithelial cells without evidence of invasion beyond the basement membrane. And before the widespread use of screening mammogram, less than 5% of the mammographic cancer were DCIS, and at present 15 to 30% of the women detected mammographic screening, they are DCIS. The greatest increase in the incidence of DCIS has been seen in women between 49 to 69 years, and DCIS can present as a palpable or non-palpable mass, Paget disease of the nipple, and incidental finding at biopsy, most commonly as mammographically detected calcifications. And a central problem in the management of DCIS is the lack of understanding of its natural history and inability to determine which DCIS will progress to invasive carcinoma during woman's lifetime. And the concordance between the risk factor for DCIS and invasive carcinoma suggests that they are part of the same disease process. And the traditional morphological classification into comedo, papillary, micropapillary, solid, cribriform types is confounded by the observation that as many as 30 to 60% of DCIS lesions display more than one histological pattern, and none of the morphological classification system predicts the risk of development of invasive carcinoma. Molecular profiling studies in DCIS have been limited by the need for histological examination of the entire lesion to relatively exclude the presence of invasive carcinoma. Two assays are now commercially available for predicting the risk of recurrence after conservative treatment for DCIS. Oncotype DX DCIS score, which employs gene expression profiling of formalin flix paraffin embedded, and provides 10-year risk of local recurrence in the patients treated with breast conservative surgery alone. And DCIS biologic risk profile, which also used for formalin fixed paraffin embedded tissue and relies on a combination of clinical and histopathological features to provide estimate of 10-year risk of local recurrence for patients treated with surgery alone, for patients treated with the surgery plus whole breast RT. And the data suggests that this assay may influence treatment decision for or against RT. Although available data indicate that DCIS lesions share many of the genetic alteration of the invasive carcinoma, a reliable predictor of the progression to invasive remains to be identified, and large scale annual supported by the Human Tumor Atlas network are ongoing. Current clinical trials for DCIS are focused on identifying the low risk cohort that can be offered active surveillance after a core biopsy diagnosis of DCIS as an alternative to standard management, as discussed further. Thank you.